Hello, this is Dr. Fakir Raveri. Welcome to this presentation on portal hypertension and cirrhosis. Cirrhosis is the irreversible fibrosis of the liver. It is the 8th leading cause of death in the United States and 13th leading cause of death globally. Once a patient is diagnosed with compensated cirrhosis, the risk of death is almost 5 times as general population. The average life expectancy in compensated cirrhosis is generally 10 to 13 years, and average life expectancy in decompensated cirrhosis can be as low as 2 years. Among patients with alcoholic cirrhosis, they found that patients who stopped drinking, about 65% of them live in 3 years, while those who continue to drink, pretty much all of them die in 3 years. Major causes of cirrhosis include hepatitis B and hepatitis C, alcoholism, and also NASH, or non-alcoholic steatohepatitis. And there are other causes as well. Pretty much anything that can cause chronic inflammatory to the liver will cause progressive liver injury and fibrosis. And over time, it can lead to portal hypertension. And as portal hypertension advances into advanced cirrhosis, patients can decompensate. And once patients decompensate, that's when you get ascites. It's estimated that the 10-year probability of getting ascites is about 47% in patients with cirrhosis. And 15% of these people who have ascites die within 1 year, and 44% die within 5 years. 10-year probability of getting hepatic encephalopathy is about 28%, and 10-year probability of getting variceal hemorrhage or bleeding is 25%. Other complications include hepatorenal syndrome and hepatocellular carcinoma. Because we have limited time in this topic, I will only focus on ascites, hepatic encephalopathy, and variceal hemorrhage, and I will not talk about other complications. In order to understand the complications of cirrhosis, first you need to understand what's the normal function of the liver. So the liver is in charge of forming and secreting the bile. It's also in charge of nutrient and vitamin metabolism. It is, of course, in charge of inactivation of various substances such as toxins, steroids, and hormones. It also synthesizes plasma proteins. Specifically, albumin is made by the liver, and also clotting factors. So if you have liver cirrhosis, you can suspect that synthesis of these proteins will be abnormal. So you will have lower albumin and lower clotting factors. So you can suspect a higher INR in patients with cirrhosis. And also, there's an immunity function to the liver. Another thing that's important to understand in order to comprehend the complications of cirrhosis is the portal venous system. So the liver, just like any other organ, will get oxygenated blood from the heart. So this will come through the hepatic artery to the liver, and then the oxygenated blood will leave the liver through the vena cava back to the heart. Now, one thing that's special about the liver is that the majority of blood that comes to the liver is actually not from the hepatic artery. It's actually through the portal vein. And the portal vein basically comes from most major other organs. So, for example, the colon, the small intestine, pancreas, and the stomach. As food or other substances are getting absorbed through the GI tract, the first thing that needs to happen is that blood goes through the portal vein to the liver first for screening and inactivating toxins before it goes back to the heart for systemic distribution. So majority of blood that comes to the liver is through the portal vein, and it's understand to know where where this portal vein comes from. So blood is flowing to the liver, and it's coming from the stomach, it's coming from the spleen, and it's also coming from the intestines and the colon. Here are some tools for assessment of liver fibrosis. I know fibrosis can happen in any organ, so that's why if you're talking about liver fibrosis, it's important to say liver. So for example, fibrosis can happen in the lungs, fibrosis can happen in the kidneys, fibrosis can happen in the heart. So any organ can have fibrosis. But when you say cirrhosis, it specifically means in the liver. So it's advanced fibrosis in the liver. Now, some of the tools that we have to assess liver fibrosis, of course, traditionally we had histologic staging by liver biopsy. So liver biopsy was known as the gold standard for staging of fibrosis and diagnosing cirrhosis. So remember from Hep C topic that fibrosis is a progressive process, and cirrhosis is pretty much the end line. So very advanced cirrhosis will cause, very advanced fibrosis will result in cirrhosis, which at that point is irreversible. You cannot go back. So once you get liver biopsy, we have a couple of tools that we can use to score the fibrosis. So the most common one is the Metavir fibrosis score that goes from F0 to F4. So F0 meaning absence of cirrhosis or fibrosis, absence of fibrosis, and F4 means specifically cirrhosis. And that's what's most commonly used for scoring liver biopsy. But in general, liver biopsy is invasive, and we have other tools. So it's not used in clinical practice anymore because we have other options. Now, one thing that we have specifically validated in Hep C patients, specifically patients who had Hep C and HIV co-infection, is the fibrosis 4 score. So basically, it's an equation that you can see here. All you have to do is plug in the age, the AST, ALT, and platelet, and we'll give you a number. And that number, if it's greater than 3.25, there's a 97% specificity. So so if your number is greater than 3.25, there's a very good chance that the patient has advanced fibrosis such as cirrhosis. On the other hand, if the FIB4 score is less than 1.45, there's a very good chance that the patient does not have advanced fibrosis. And it's easy to use this in the clinic. Another thing that we have is the FibroSure that uses, it's a kit that you can use. It's more accurate, but it's expensive. It uses 6 specific biomarkers. We're not going to talk about that. One thing that's used most commonly in clinical practice in hepatology clinics is the FibroScan, which is the transient elastography. It basically uses ultrasound. It's not invasive. Basically, it's just like any other kind of ultrasound. The patient just lies down on a bed and they use the probe to shoot ultrasound waves at the patient. And basically, as the waves go through the liver, it measures the elasticity or the pressure inside the liver. And it reports a number in kilopascals. And it's been validated based on what the number is. It correlates with the Metavir scores. And that's what they typically use in order to diagnose cirrhosis. And these are mostly validated in patients with Hep C and also in patients with NASH. But we can extrapolate and use it in other causes of cirrhosis as well. They're pretty accurate in diagnosing cirrhosis non-invasively. Once the patient has cirrhosis, we use the Child-Turcotte-Pugh or Child-Pugh classification for short, Child-Pugh, to classify cirrhosis. So the different things that we look at is encephalopathy, for example, ascites, bilirubin, albumin, and INR. And then you can see you can get different points. So you can get 1 point, 2 point, or 3 points based on these different categories. So for example, if a patient with cirrhosis does not have ascites or encephalopathy, they get 1 point for each. If their bilirubin is less than 2, they also get 1 point. If their albumin is greater than 3.5, they get another point. And if their INR is less than 1.7, they get 1 point. So you add up the points for 1, 2, 3, 4, 5. And then for points 5 to 6, it's considered class A. For a total points of 7 to 9, you get class B, and class C is 10 to 15. So based on Child-Pugh, you can have class A cirrhosis, class B, or class C cirrhosis. So in general, class A is considered compensated cirrhosis, whereas class B and C are considered decompensated cirrhosis. Here are some reliable resources when approaching patients with cirrhosis. We do have so AASLD is the American Association for the Study of Liver Disease. That's the primary organization for hepatology guidelines in the United States. The European counterpart is the EASL, or the European Association for the Study of the Liver. For the most part, we use the AASLD guidelines. The only exception is for hepatic encephalopathy. These two organizations actually made the guidelines in collaboration. So the hepatic encephalopathy guidelines from 2014 are by AASLD and EASL together. So we do have guidelines, AASLD guidelines for gastroesophageal varices and variceal hemorrhage in cirrhosis from 2007. We have Ascites guidelines from 2012. We also have an updated portal hypertensive bleeding consensus guidance that was just published in January. And then outside of cirrhosis, we do have guidelines for ulcer bleeding. So I will talk about ulcer bleeding. That includes patients who do not have cirrhosis. So that's in general for the general population. Anybody who has ulcer bleeding, will, whether they have cirrhosis or not, we will use these guidelines. The first learning objective is given a patient with portal hypertension, recommend appropriate pharmacologic prophylaxis to prevent clinical decompensation. What exactly do we mean by portal hypertension? So there is the hepatic venous pressure gradient, which is the difference in pressure between the portal vein and the hepatic vein, and it's normally 3 to 5 millimeters of mercury. So anything above this range is considered portal hypertension. And then the severity of it depends on how high it is. So if it's more than 5 but less than 10 millimeter of mercury, it's referred to as mild portal hypertension, whereas if it's greater than or equal to 10 millimeters of mercury, it is referred to as clinically significant portal hypertension, or CSPH. So we do use these two cutoffs to classify the severity of portal hypertension. Now, if someone has decompensated cirrhosis, for the most part, they happen to have an HVPG of greater than or equal to 12. So it's not to say that if anybody who has greater than or equal to 12 has decompensated, but in general, anybody who has decompensated cirrhosis, they will have a HVPG of at least 12 millimeter of mercury. And I will explain more about these. But first, let's see how we actually measure hepatic venous pressure gradient.
The hepatic venous pressure gradient, HVPG, is the most reliable way to measure portal pressure. A digital X-ray fluoroscope and a monitor with a pressure recorder are needed. Measurements are performed with a catheter that has an inflatable balloon on its tip. Under sterile conditions, a needle is placed in the right jugular vein, preferably under ultrasound guidance. After aspiration of dark blood confirms that the needle is in the vein, a guide wire is introduced into the jugular vein, and the needle is exchanged with a catheter introducer sheath. The balloon-tipped catheter is advanced into the right hepatic vein. Adequate occlusion of the hepatic vein is confirmed by inflation of the balloon and dye injection. Pressures are recorded when the balloon is deflated and when it is inflated. The HVPG is calculated by subtracting the free pressure from the wedge pressure. Measurements are performed in triplicate. Determination of the HVPG is the safest and most reproducible method of measuring portal pressure. In patients with cirrhosis, the HVPG can predict the development of varices. A reduction in the HVPG is related to a reduction in the incidence of varices and variceal hemorrhage. The HVPG is the best surrogate marker in portal hypertension and should be measured in every trial involving pharmacologic therapy.
So that's how HVPG is measured. Now, when we say compensated portal hypertension, note that there are no complications. So complications of portal hypertension is absent, whereas you will have complications when it's decompensated. So those complications include acute variceal hemorrhage or bleeding. And also if someone had previous variceal hemorrhage without other complication, or previous variceal hemorrhage with other complications. Now let's take a look at mild portal hypertension. So in mild portal hypertension, which is defined as HVPG of greater than 5 but less than 10 millimeters of mercury, no varices or other complications are present. So this is in general in compensated cirrhosis. There is very low risk of clinical decompensation in the following 5 years based on the studies that we have. So the goal of therapy for these patients is to prevent development of clinically significant portal hypertension. So that would be if you have a HVPG greater than or equal to 10 millimeter of mercury, and that is our goal, to prevent that. So how do we do that? So first and foremost is eliminating or suppressing the etiologic agent. So for example, if someone has Hep B or Hep C, if you treat that, then you can potentially prevent progression from mild portal hypertension to clinically significant portal hypertension. One thing that happens often is if patients have alcoholic cirrhosis, so the easiest thing for them is to stop drinking. And also if you have other causes, one example is if someone has iron overload, that can cause oxidative stress to the liver. So if you limit that iron overload and reduce the iron content, then we can potentially prevent progression from mild portal hypertension to clinically significant portal hypertension. Now, one thing that could potentially be beneficial is the use of statins in this patient. Statins decrease hepatic fibrogenesis. They improve intrahepatic endothelial dysfunction. They reduce portal pressure and also improve liver perfusion and liver function. Now, at this time, we do not have prospective randomized trials of statins in patients with compensated cirrhosis. So, this is not a strong recommendation, but, we could potentially put patients on Zocor 20 milligram for 1 month and then 40 milligram daily after that. This is one thing that's been shown with limited data to be beneficial. Now, other drugs that act on portal flow, for example, non-selective beta blockers, and I will talk about how non-selective beta blockers help in general. Those drugs will be mostly ineffective if patients have mild portal hypertension. And the reason for that is that these patients with mild portal hypertension, in these patients, hyperdynamic circulatory state is not fully developed, so using a beta blocker will not really help them. Next, we have patients who progress into clinically significant portal hypertension. So this is defined as HVPG of greater than or equal to 10 millimeters of mercury. So there should be an equal sign here. So for these patients, the goal of therapy is prevention of clinical decompensation. For management of this patient, there is no evidence at present to recommend the use of non-selective beta blocking agents for prevention of varices. And that's because in 2005 there was a study that was published in New England Journal of Medicine that compared timolol to placebo, and there was no difference between timolol and placebo. So for that reason, beta blockers are not recommended. Non-selective beta blockers are not recommended in this patient at this time. You can still continue any management strategies that were applied to mild portal hypertension for these patients as well. And finally, patients progress into gastroesophageal varices. Now, for this patient, endoscopically proven GEV or gastroesophageal varices are proven through EGD. So EGD, I will talk about EGD in a little bit, but it stands esophageal gastroduodenoscopy. So basically, you can for sure you can call this endoscopy. And I'll show you how EGD is done in the next learning objective. Now, the lowest HVPG in this patient is typically 10 to 12 millimeters of mercury. The goal of therapy is primary prophylaxis of variceal hemorrhage. So at this point, patients do have varices. So what we want to do is prevent these varices from bleeding. Now, in studies, it's been shown that if we reduce the HVPG to less than or equal to 12 millimeter of mercury, or if you reduce the HVPG by at least 20% from baseline, it's been shown to be protective for development of variceal bleeding. So if we do, so let's see how we can actually reduce that HVPG by medical therapy or pharmacologic therapy. First, let's look at different patient populations because GEV is very broad. So let's talk about prevention of first variceal hemorrhage in patients with medium or large esophageal varices. So these are varices in the esophagus. So for these patients, it's recommended to use non-selective beta blockers. Carvedilol has also been shown to be effective. And also endoscopic variceal ligation or EVL is recommended. But combination therapy with any of these is not recommended. So just a single agent. So either a non-selective beta blocker, carvedilol, or EVL. So that's for medium and large esophageal varices. For small esophageal varices, again, non-selective beta blockers are recommended if patients has high risk. Carvedilol has not been studied in this patient, so it's not recommended. So if you do use beta blockers, what constitutes optimal response is if HVPG is reduced to less than or equal to 12 millimeters of mercury, or if you decrease HVPG by at least 20% from baseline. Heart rate, although we do monitor heart rate, it does not correlate with changes in HVPG, but we do monitor it for safety. So that was for esophageal varices. When it comes to gastric varices, it can get really complicated. In general, non-selective beta blockers are recommended. But the data is not as strong. The data are not as strong for gastric varices as it is for esophageal varices. So for the most part, just focus on esophageal varices. Now here are the recommended doses for the different beta blockers. So propranolol 20 to 40 milligram by mouth twice a day, and we do adjust the dose every 2 to 3 days to maximum dose. And we want to target a resting heart rate of 55 to 60 beats per minute. And we want to maintain systolic blood pressure at 90 millimeters of mercury or greater. So if the systolic blood pressure drops under 90, you need to discontinue the beta blocker. Or if the heart rate goes under 55, because at that point it's not safe to continue these agents. Now for nadolol, 20 to 40 milligram by mouth once a day is recommended, with the same therapy goals for heart rate and systolic blood pressure. For carvedilol, we start with 6.25 milligram once a day, or you can do 3.125 milligram twice a day. And we only monitor systolic blood pressure. So carvedilol doesn't affect heart rate as much as non-selective beta blockers. So there's no need to target a heart rate of 55 to 60. And of course, for EVL, which is the procedure, it's done every 2 to 8 weeks until eradication of varices. The next learning objective is given a patient with variceal hemorrhage, design appropriate pharmacologic management. For esophageal variceal bleeding, patients are generally considered decompensated. Acute hemorrhage is a medical emergency, so patients typically need to be admitted to the ICU. Goal of therapy is to control bleeding to prevent early recurrence within 5 days and prevents 6-week mortality. Now, of course, when patients have active bleeding, what you want to do is to assess them to see if they need blood transfusion or packed red blood cell transfusion. In general, we do use the restrictive strategy. So that means if hemoglobin is less than 7, then they need transfusion to maintain 7 to 9. This is in general. So if patients do have cardiovascular comorbidities, then we actually use a hemoglobin cutoff of 8. So for those patients, if hemoglobin is less than 8, then they need to get transfusion. Now, once patients with variceal bleeding, once patients with varices they start having variceal hemorrhage, they do need to get antibiotics. So ceftriaxone 1 gram once a day for a maximum of 7 days should be started as soon as possible. And that's because patients with variceal hemorrhage are at high risk of getting systemic infection, which is associated with high mortality. So we do treat them with ceftriaxone. They should also be started on vasoactive agents as soon as possible, and I will talk about these agents in a little bit. And then once these strategies have been taken care of, then EGD should be performed within 12 hours of admission, once the patient is hemodynamically stable. So now let's talk about EGD, or esophageal gastroduodenoscopy. So once the EGD is performed and variceal source is confirmed or suspected, then EVL should be performed. For some patients, an early or preemptive tips within 72 hours from EGD or EVL may be beneficial, up to 7 days. Now, if patients do not get tips, then vasoactive agents that were started before EGD, they should be continued for 2 to 5 days. And also, at this point, patients should be started on non-selective beta blockers once vasoactive drugs are discontinued. So, which happens after 2 to 5 days. Now, transjugular intrahepatic portosystemic shunt or TIPS is a procedure that basically connects, because of the increased pressure in the portal vein. What they do is they basically place a stent in here to basically increase the blood flow to decrease the pressure that was building up in the portal vein. So that's something that you can do in order to decrease the portal vein pressure, which can potentially decrease the bleeding risk from or the bleeding rate from the varices. Here are the vasoactive agents for acute variceal hemorrhage. So for the most part, octreotide is what we use. The initial dose is 50 microgram IV bolus, which can be repeated in the first hour if ongoing bleeding is going on. And then we do continuous infusion of 50 microgram per hour. And this goes 2 to 5 days. So during those 5 days, then you'll have some sort of procedure to stop the bleeding. And then once you stop the octreotide, then you start your non-selective beta blockers. Other agents include vasopressin, somatostatin, and terlipressin. So that was for esophageal variceal bleeding. For gastric variceal hemorrhage, pretty much the initial management is similar to that of esophageal variceal bleeding. Endoscopic therapy is really important for these patients. So basically, the scope goes into. Now, this picture is in the esophagus, but the same concept applies to the stomach. So the scope goes in and finds the site of bleeding, and then they can either have cyanoacrylate injection, or they can actually do ligation. So once they ligate the varices, it will stop the bleeding. So once acute variceal bleeding is taken care of, we want to prevent this from happening again. So we do have secondary prophylaxis of variceal hemorrhage. When it comes to the esophageal variceal hemorrhage, patients who recover from the first episode have a high rebleeding risk, as high as 60% in the first year, and mortality can be as high as 33%. So goal of therapy for this patient is prevention of additional complications such as variceal rebleeding, and also to improve survival. So because mortality rate is high, we want to decrease that mortality rate. So first line recommendation is to use a combination of non-selective beta blocker and EVR. So once patients get ligation, we do start the non-selective beta blockers on these patients. And the patients with TIPS placed do not need to non-selective beta blockers or ligation. So TIPS is pretty effective. In fact, if patients who don't get TIPS and they are on non-selective beta blocker and ligation and that fails, so they get rebleeding, then TIPS is definitely recommended for these patients. For gastric variceal hemorrhage, again, non-selective beta blockers with endoscopic variceal therapy is recommended. Another thing that can actually happen for gastric hemorrhage is something that's called balloon occluded retrograde transvenous obliteration, or BRTO. So in this picture you can see what this means. So basically they deploy these balloons to basically occlude the source of the bleeding. That way you can stop the bleeding by just basically blocking the source of the blood. The next learning objective is, given a patient with non-variceal upper GI bleeding, recommend pharmacologic management. So upper GI bleeding is defined as bleeding from the esophagus, stomach, or duodenum. In patients with cirrhosis specifically, upper GI bleeding could be from varices. So variceal bleeding account for 60 to 65% of upper GI bleeding in patients with cirrhosis. Now, erosions are breaks confined to the mucosa and should not cause severe bleeding, because veins and arteries are not normally present in the mucosa. So while variceal bleeding can happen in cirrhotic patients, in upper GI bleeding can happen in anybody, whether they have cirrhosis or not. So in general population, upper GI bleeding can happen, typically due to peptic ulcers. So here are different causes of upper GI bleeding in anybody. So varices obviously happens in patients with cirrhosis, but for those patients who do not have cirrhosis, the most common is peptic ulcer, which can also happen in patients with cirrhosis. And you guys learned about peptic ulcers yesterday. It's typically due to H. pylori infection or NSAID induced. And there are less common causes of upper GI bleeding, but since we don't have time to cover every topic, we will in this topic I will focus on bleeding from peptic ulcers. Initial therapy before endoscopy. So obviously the the main strategy for stopping the bleeding is endoscopy. So the question is, what should we do before the patient actually gets the endoscopy? Because the patient needs to be hemodynamically stable. So, again, transfusion of packed red blood cells with the same cutoff. So hemoglobin less than 7 in general, or less than 8 if patient has pre-existing cardiovascular disease. There's the question of whether proton pump inhibitors are effective or should we start them before endoscopy. So in general, pre-endoscopic PPIs may be considered. Typically 80 milligram IV bolus followed by 8 milligram per hour continuous infusion. However, PPIs do not improve clinical outcomes such as further bleeding, surgery, or death. If endoscopy will be delayed or cannot be performed, PPI is definitely recommended to reduce further bleeding. And then, of course, the endoscopy itself happens, which is the most effective way of controlling the bleeding. And then once the patient gets the endoscopy, after successful endoscopy, I should say, PPI therapy, again with 80 milligram IV bolus followed by 8 milligram per hour continuous infusion for 72 hours should be given to patients who have an ulcer with active bleeding, a non-bleeding visible vessel, or an adherent clot. So these are high-risk patients. Patients with ulcers that have flat pigmented spots or clean bases can receive standard PPI therapy, such as oral PPI once daily. Now, in this picture, you can see different recommendations for patients based on their risk. So the risk is determined through the endoscopy. So once the patient gets scoped, based on what they see through the, through endoscopy, they can either have a clean base, they can either have flat pigmented spot, adherent clot, or active bleeding or visible vessel. So in general, adherent clot and active bleeding or visible vessel are considered very high risk, whereas clean base is considered the least risky for as far as rebleeding and mortality. So for those patients who are low risk, basically through endoscopy they find what's going on, but they don't necessarily do endoscopic therapy if they're low risk. And then what they can do is, since these patients are low risk, you can have once daily PPI therapy. And then patients typically, if there's a clean base, they get discharged and go home. If they have a flat pigmented spot, they may be observed for 1 or 2 days and then get discharged, assuming there are no other problems to keep them in the hospital. Now, for high-risk patients, basically, obviously, if you have active bleeding, you do need that endoscopic therapy to stop the bleeding. If they have adherent clot, it may be, endoscopic therapy may be considered. And then for medical therapy, after endoscopy, you do need intensive proton pump inhibitor therapy. And these patients are typically held in the hospital for 3 days, just to observe them to make sure they don't have rebleeding. And then after 3 days, unless they have other reasons to stay in the hospital, they can be basically discharged if the bleeding has been managed beyond 3 days. Now, what exactly does intensive PPI mean? So, based on the latest guideline that we have in North America from 2012, the recommendations were 80 milligram IV bolus followed by 8 milligram per hour continuous infusion for 72 hours. More recent data suggests that you can also use PO or IV bolus, such as 80 milligram, followed by intermittent high-dose PPI therapy, such as 40 to 80 milligram twice daily for 3 days. Now, this is at the moment, some institutions are basically implementing this. The European guidelines have updated in 2015, and they have used that study, which you were required to read, to make this recommendation. Our guidelines haven't updated yet, so they still recommend 80 milligram followed by 8 milligram per hour continuous infusion. But some hospitals are starting to implement the intermittent dosing. Now, if patients have high risk, they will require 2 weeks of twice daily dosing of PPI, and then they can go to once daily dosing. And what high risk means is patients with findings, with endoscopic findings and clinical factors that are of high risk, such as hemodynamic instability, older age, major coexisting conditions. Those patients need to be on twice daily PPI for at least 2 weeks before going to daily. Otherwise, they can just continue once a day PPI. So once we manage that episode of bleeding, we want to prevent this from happening again. So we do have secondary prevention of ulcer bleeding. Patients with H. pylori, basically you need to treat H. pylori. So eradication of H. pylori is recommended for these patients to prevent this ulcer from happening again. Patients who are on NSAIDs, that excludes low-dose aspirin. I'll talk about low-dose aspirin in a little bit. But if patients are on NSAIDs and they had NSAID-induced ulcer bleeding, they should discontinue NSAIDs. And if they really need that NSAID, they should be on a COX-2 selective NSAID, and they should get a PPI as long as they are on a COX-2 selective NSAIDs to prevent bleeding. Now, for low-dose aspirin, it's a question of why they are getting that low-dose aspirin. If it's for primary prevention of cardiovascular disease, it's recommended to discontinue aspirin permanently because the risk outweighs the benefit. Now, if that low-dose aspirin is for secondary prevention of cardiovascular disease, now the benefit actually outweighs the risk, so it is recommended to resume aspirin 1 to 7 days after bleeding stops in most patients. And once you do, the patient should continue PPI therapy in the long term. So as long as they are getting aspirin, they should also be on a proton pump inhibitor. Now, that was for management of the ulcer bleeding. Now, in general, patients who have GI bleeding, the question is, do they need antibiotics for prophylactic antibiotics to prevent infection? So the question is, well, what patient population are we talking about when it comes to upper GI bleeding? So in patients with cirrhosis, if they have variceal bleeding, definitely they need short-term prophylactic antibiotics, as I mentioned earlier. It's shown to decrease rate of bacterial infection as far as increase survival. So we can decrease mortality by giving antibiotics to patients with variceal bleeding. Now, if you have non-variceal bleeding, such as ulcer bleeding, it's a matter of whether this is happening in patients with cirrhosis or no cirrhosis. So if you have ulcer bleeding in patients with cirrhosis, again, you need to use prophylactic antibiotics. There's data to show that patients who have cirrhosis and they have ulcer bleeding, or any other kind of upper GI bleeding, use of antibiotics significantly reduces bacterial infections. And it also seems to have reduced all-cause mortality, bacterial infection mortality, rebleeding events, and hospitalization links. So if someone has non-variceal bleeding and has cirrhosis, definitely use the same prophylactic antibiotics. Now, if someone has ulcer bleeding and they do not have cirrhosis, there is absolutely no data to support prophylactic antibiotic use. So if someone comes in with ulcer bleeding but they do not have cirrhosis, there's no need for antibiotics at this point. The next learning objective is, given a cirrhotic patient with ascites, recommend appropriate management. So ascites is the most common complication of cirrhosis. It's associated with poor quality of life, increased risk of infection and renal failure, and a poor long-term outcome. So what exactly is ascites? So basically, with patients with advanced cirrhosis, fluids can leak into and full abdominal cavity. So this is in the abdominal cavity you get all these fluid collection. So they start to gain weight as this fluid collects in this area, and that's because all the because of the vasodilation that occurs when patients have advanced cirrhosis. all these vessels become leaky. So fluids just come out of the blood vessels and collect into this abdominal cavity. Diagnostic abdominal paracentesis should be performed, and ascitic fluid should be obtained from inpatient and outpatient with clinically apparent new onset ascites. So paracentesis, basically they will use a needle and draw fluids out of this area. So once they draw that fluid, they can send it to the lab for analysis. So the most important thing that you should know when it comes to ascitic fluid analysis is the serum ascites albumin gradient, or SAAG. What it is that you should also measure the serum albumin in the same day, and then you subtract the ascitic albumin level from serum albumin, and that gives you the gradient. So if the gradient is greater than or equal to 11 grams per liter, it's a strong indication of portal hypertension. So we know that that's important to know, because you want to know is it due to when you have ascites, is it due to the cirrhosis or is it due to another cause? So that's why we need to know that SAAG gradient. And while you do get some fluids through paracentesis, you should also send it for bacterial culture if infection is suspected. So if someone has a fever, if their white blood cell is increased, or if they have abdominal pain or tenderness, so if you suspect infection, also send that fluid for analysis in the microbiology lab. So once portal hypertension, when you get these changes in physiology, as I mentioned, vasodilation makes these arteries to be leaky. So increase in capillary pressure results in lymph formation that exceeds lymph return, and then these fluids collect in the peritoneal space. So vasodilation, in the portal system just results in more blood going there, so the pressure increases. Whereas that same vasodilation in the normal systemic arteries, results in arterial underfilling. So that would activate vasoconstrictors and anti-natriuretic factors. So once you get these factors released, then you will have sodium and water retention. So if you have sodium and water retention, then you have expansion of plasma volume, so that continues to add fluids to the ascites. And then the other things that can vasoconstrictors and anti-natriuretics do is that they can impair free water excretion. So these patients typically have hyponatremia. And then it can also cause renal vasoconstriction, so patients can get something referred to as hepatorenal syndrome, which is beyond the scope of this topic. I will not talk about hepatorenal syndrome. So what should we do for patients with ascites? So first line treatment, of course you need to know that SAAG to begin with, because if the SAAG is low, like less than 11 grams per liter, patients typically don't respond to these first-line therapies. But for those who have SAAG greater than or equal to 11, one of the most important things is cessation of alcohol use. Assuming if they have alcoholic cirrhosis. Then dietary sodium restriction is very important. So we do want to restrict sodium to 2 grams a day, 2,000 milligram a day. That's fluid restriction is not necessary unless sodium is less than 125. In fact, chronic hyponatremia in cirrhotic ascites patients is usually not morbid unless it is rapidly corrected at the time of liver transplantation, for example. So if they have mild hyponatremia, it's not reason to have fluid restriction. Fluid restriction typically doesn't work. Now, what they really need to be on is dual diuretics. Really, we're not. The reason we're using diuretics is not so much for the diuresis, because we're not really trying to get rid of the fluids, but rather it's for their natriuresis. So we're trying to get rid of sodium. Typically, we give them dual diuretics in the morning. Giving them in the morning, it not only improves adherence, but it will also avoid nocturia, so they don't have to wake up. Patients don't have to wake up in the middle of the night to pee. The most commonly used regimen is spironolactone and furosemide, and you have to use this in a ratio of 100 milligram to 40 milligram. So spironolactone 100 milligram and furosemide in 40 milligram. And you can titrate the dose. You can increase the dose every 3 to 5 days, but you have to maintain this ratio. And the reason we have maintained this ratio is because we're trying to get rid of sodium, but we want to make sure that potassium stays, the same. So if you have potassium-sparing diuretic, if you use this combination in this ratio, it will hopefully maintain potassium at the same levels. Another thing that's recommended for this patient is albumin 25 gram weekly for 1 year, followed by infusion every 2 weeks, which has been shown to improve survival compared to diuretics alone. So, in addition of spironolactone and furosemide, you can also consider albumin. And of course, as I mentioned earlier, if the patients are NSAIDs, it should definitely be discontinued if they have ascites. So NSAIDs can also cause, retention of fluids and sodium in the body. So because NSAIDs also act on the kidneys, so they should definitely be discontinued. Anybody with cirrhosis who has ascites should not be on NSAIDs. With the exception of a low-dose aspirin. And so ultimately, these patients will need to be evaluated for liver transplantations, because at this point, these patients are decompensated, so they will need liver transplantation. Another thing that we can do is therapeutic abdominal paracentesis. So, paracentesis, as I mentioned earlier, you just use a needle to draw fluids for analysis. But another thing that we can do is, actually draw a lot of fluids out as a therapy. So, if they have these fluids collected, if it's too much, we can just, it's been shown that a single 5-liter paracentesis can be performed safely without requiring colloid infusion. Now, if you need to get more than 5 liters of fluids out of the ascitic fluids, you actually need to administer IV albumin. It's recommended to use 6 to 8 grams per liter of fluid that's removed. Another thing that can happen with patients with ascites is something referred to as spontaneous bacterial peritonitis, or SBP. So SBP involves translocation of bacteria from the intestine to lymph nodes with subsequent bacteremia and infection of ascitic fluid. Unfortunately, SBP has a high mortality rate. The most severe complication of SBP is the hepatorenal syndrome. So it's been, it's recommended to use IV albumin 1.5 gram per kilo of body weight at diagnosis, and then do 1 gram per kilo 48 hours later. So that would be on day 3. It helps to prevent the hepatorenal syndrome and improve the probability of survival. Suspicion for infection includes abdominal pain or tenderness, fever, encephalopathy, renal failure, acidosis, or peripheral leukocytosis. So actual diagnosis of SBP is once you get ascitic fluid and you get a PMN of at least 250. That would basically confirm SBP. Now, if the PMN is less than 250, but if the patient has a fever of at least 100 degrees Fahrenheit or abdominal pain, that can also confirm diagnosis of SBP. What typically causes SBP is aerobic gram-negative bacilli, most commonly E. coli that comes from the gut. So for empiric treatment of SBP, we typically use IV third-generation cephalosporins. The guidelines, which are from 2012, They recommend cefotaxime 2 gram every 8 hours because we have a lot of data with it. There's also some data with ceftriaxone 1 gram every 12 to 24 hours, and that's what typically is used in clinical practice. So, ceftriaxone is easy to dose, and, it can potentially be dosed once a day dosing. So that's easy to do. It's not renally adjusted, so ceftriaxone is what we use in clinical practice. Now, if someone gets SBP from the hospital, you should use your local antibiogram to guide therapy, especially if someone has had recent beta-lactams, just to make sure that, if they have potentially drug-resistant E. coli, such as, ESBL producing E. coli, for example. Alternative to ceftriaxone or third-generation cephalosporin is oral fluoroquinolones. And the total duration of treatment is 5 days. So that includes both empiric window and also definitive therapy. So if you get the cultures back and if you streamline antibiotics, total duration of therapy should be 5 days. So once someone gets SBP, we want to make sure this doesn't happen again. So we do have Svp prophylaxis, especially if someone has, if someone develops new ascites and they don't have, if you don't have suspicion for an infection, you can still do you can do Svp prophylaxis. So we use the same antibiotic ceftriaxone for 5 days. And then for patients who actually had SBP and you want to do secondary prophylaxis, you should use long-term. You can potentially do long-term. There's limited data, that's why I say potentially. So one recommended agent is ciprofloxacin once weekly. So by long-term, I mean you just continue this for life. The 5-day regimen is for patients who just newly developed SBP. Ascites. So if someone just developed ascites and you want to do prophylaxis for SBP while we manage the ascites, you just do 5 days of antibiotics, just to make sure they don't have SBP, since the mortality rate is high with SBP. Now, someone who did have SBP, you want to treat them with either Bactrim, Trimsulfa, or Cipro for potentially for life. The last learning objective is given a cirrhotic patient with hepatic encephalopathy. Recommend appropriate regimen. Hepatic encephalopathy is a frequent complication of and one of the most debilitating manifestations of liver disease. By definition, hepatic encephalopathy is a brain dysfunction caused by liver insufficiency and/or portosystemic shunting. It manifests as a wide spectrum of neurological or psychiatric abnormalities, ranging from subclinical alterations to coma. Now, the pathogenesis, it typically involves fibrotic liver, prevents flow of blood through liver for processing. So less NH3 is filtered through the liver. It means that less of it is converted to urea. So ammonia, NH3 is ammonia, continues in circulation, and at high levels it can actually cross blood-brain barrier, leading to altered mental status. So this altered mental status is largely due to ammonia. So in the colon, what typically happens is that we do have these, normal flora, so bacteria that normally reside in the colon, and they have the job of, converting proteins, like as part as protein metabolism, to ammonia. So because ammonia is a byproduct of these normal flora, ammonia gets absorbed into the system, and in a normal person without cirrhosis, this ammonia goes into the liver and is converted to urea, so it doesn't really cause any problem. The problem is if someone has cirrhosis and their liver is not capable of urea cycle to process ammonia, this ammonia will accumulate in circulation, and then at high levels it can cross the blood-brain barrier and go into the brain. And into the brain, it is neurotoxic and it can cause abnormally functioning neurons, which results in altered mental status and hepatic encephalopathy. So this is what happens in the chronic liver disease such as cirrhosis. Now in the acute setting, it can also cause brain edema. So this happens in someone who develops like acute liver disease, but what we see in chronic liver disease such as cirrhosis is hepatic encephalopathy. Now for therapy for episodes of overt hepatic encephalopathy, we do recommend lactulose as first line. So the way we use lactulose is initial dose of 25 mL of lactulose syrup every 1 to 2 hours until at least 2 soft or loose bowel movements per day have achieved. And then we can titrate it to maintain 2 to 3 bowel movements per day. The way lactulose works, it actually is kind of like a prebiotic, so bacteria will actually use it, and they will degrade lactulose. As a result, it actually makes the pH of the gut very acidic, and under acidic pH, ammonia will actually be converted to ammonium, so ammonium will have a positive charge, and because of that, it will not be absorbed from the gut into the portal system. So that helps in reducing the ammonia levels in the body. Another thing that it does, as part of that change in pH, it actually enhances diffusion of ammonia from the blood to the gut. So it also, takes some of that ammonia from the blood and take it into the gut. And then the last thing lactulose does, it actually produces an osmotic effect, which is responsible for the bowel movements. Another agent that we have that we can use is rifaximin. It is an effective add-on therapy to lactulose. So we have to add it to lactose because when they studied this, so this was lactulose plus rifaximin. It wasn't rifaximin alone. So it's very effective in prevention of overt hepatic encephalopathy recurrence. Other things that we have limited data for is, for example, oral branched-chained amino acids. They can be used as an alternative or additional agent to treat non-responsive patients, especially if patient cannot tolerate, lactulose or rifaximin because of, diarrhea or, rifaximin is expensive. We also have limited data for IV LOLA or ornithine L-aspartate. It can be used as an alternative or additional agent, just like branched-chained amino acids. Neomycin is an alternative choice for treatment of overt hepatic encephalopathy, and lastly, metronidazole is an alternative choice. Now, the way rifaximin works, it actually is an antibiotic. It's rifamycin, and it's not. It's an oral agent that's not absorbed. So if it's not absorbed, it stays in the gut, and it kills some of those bacteria. So by killing the bacteria in the gut, it will prevent the formation of ammonia. So the same is true for metronidazole and neomycin, but these are systemically absorbed. So we prefer rifaximin because it's not systemically absorbed. Because if they're systemically absorbed, then it can affect other flora in your body. So this is for treatment, and then once someone has hepatic encephalopathy, we want to prevent that from happening again. So we have prophylaxis, secondary prophylaxis. So we do continue this patient with lactulose. We can also add rifaximin as an add-on to prevent this from happening. And we have very limited data when it comes to prevention of hepatic encephalopathy. That concludes this presentation.